So let's talk about new classes that we've got actually in our pockets right now. So the most recent drug to be approved was panobinostat, based on the Panorama 1 trial and the Panorama 2 trial, sort of as a parallel trial in refractory myeloma. How do you all view some of that data? And I think there's new data that was presented on Panorama 1 recently.
Yes, so indeed, again, panobinostat, an orally available histone deacetylase inhibitor, has previously been published with bortezomib 1-4-8-11 schedule versus placebo bortezomib, showing an improved progression-free survival. There were two trials that came out this year's ASCO. One was a planned analysis of those patients who had received both prior bortezomib and either lenalidomide or thalidomide. So that's a group that's a real challenge for all of us. And that showed that there was an overall response rate of 58.5% in the patients that received panobinostat compared to 41.4%, and a higher progression-free survival by 4.8 months, which in a group that's already had bortezomib and either lenalidomide, thalidomide, I think is an impressive amount of time. The second analysis that was done was regarding depth of response, and that the deep responses near CR and CR was higher with the panobinostat regimen, 27.6 versus 15.7, and the deep responses, the CR patients, had a progression-free survival of 16.5 months, which is pretty impressive, both for its higher progression-free survival and a higher quality of response. The problem, of course, is that when you combine it with bortezomib, lots of diarrhea, lots of fatigue, 35% diarrhea, 25% fatigue, and that means the ability to administer it and the impact on quality of life, I think, is going to be a real challenge for widespread implementation. There were two abstracts, one combining panobinostat with lenalidomide and one combining panobinostat with carfilzomib, which are exploratory trials. But one thing that really impressed me, lenalidomide panobinostat is all oral, but no significant GI toxicity or fatigue. The same thing when it was combined with carfilzomib. Again, the diarrhea was 4% instead of 30%. The fatigue also was substantially reduced. So the idea that how an HDAC partners with a novel agent, I think, is going to be an important question moving forward. So I think right now panobinostat is still finding its pathway, and that optimal utilization is still unclear.
Okay. Jatin, you did an upfront study with RVD plus panobinostat. Tell me a little bit about where you think it may fit in.
Yeah, so I mean, I agree with everything that Morie mentioned. I mean, I think interesting when you look at Ajay Chari's work with len plus panobinostat. In that experience with 20 patients, 15 out of the 20 were len refractory. Several others had RVD that had a minor response to therapy. They had a 40% response rate, and several patients on, including a few patients with 1Q with long, durable responses, which is and very safe. So there wasn't any toxic deaths that we've seen with a prior len-dex combination study that we've done before. So I think there's some really intriguing data there that we see, and this is in all len refractory patients. So I think that does open up an opportunity to look at HDACs with IMiDs now. And I agree with your experience. We did a carfilzomib panobinostat trial as well as you have, and we haven't seen the same degree of diarrhea that we see with bortezomib combination. And I think as this combination with bortezomib goes into the community, and we're using weekly sub-Q bortezomib, which is different than the Panorama 1, which used twice weekly IV, then I think that will change what we experience in the community as we use it with diarrhea and fatigue. So I think that, and as we move it up front, and as we talked about a bit earlier, when you use your active therapies and you use them up front, I think that's the best way to move forward. And so we did a trial with RVD plus panobinostat for newly diagnosed patients. It was very well tolerated, so we didn't see the same degree of diarrhea, patients coming off trial with a very nice improvement in the depth of response. And so when we looked early on, after 3 to 4 cycles of therapy, almost 40 to 50% of patients at an early time point were already in a CR or near CR state. So I think that it can improve depth of response early, which is really one of the goals of induction therapy. So, and in I think, a well-tolerated fashion. So.
Okay. Noopur, you've done a lot of science with HDACs. Tell me where you think it fits in.
So, well, I agree with Jatin, actually. We need to try and explore other combinations with these HDAC inhibitors. We worked on a more selective HDAC inhibitor, as you know, Sagar. We worked on ricolinostat, which is more HDAC6 selective or more specific to HDAC6. And we've combined it with proteasome inhibitors. We've combined it with the IMiDs. And interestingly enough, when you use this epigenetic inhibitor, you actually partner it better with the IMiDs. So going forward, we are actually combining it with pomalidomide and ricolinostat, where we're not seeing the same toxicity that you see with a proteasome inhibitor. So I do think HDAC inhibitors have a future. I agree with Morie. I think it's still finding what the best partners are. And in our mind, I think the IMiDs may be the better partner for the HDAC inhibitors going forward.
Okay.
You know, one thing that's interesting is when you look back at the history, and Noopur alluded to this, HDACs probably represent the best example of bench to bedside. I mean, it was the, you know, the group of Dana-Farber starting with a PNAS paper looking at, you know, the HDAC effect on the response that was seen to bortezomib that ultimately led to this clinical trial. And so the science is very strong behind this. I think even when you look at, you know, the vortinostat clinical trial, you see there's a biologic effect. The challenge has been how to position this into the clinic. And the fact that you have to do a clinical trial that uses a schedule that for the most part we don't use anymore for bortezomib, that really creates challenges for the clinician, because then, you know, how am I supposed to use this in the real world? So I'm just delighted to hear about, you know, the opinions on combination with IMiDs, which by the way may have very important effects also on protein metabolism in the cell. And if, you know, if that's a winning combination, you know, that's great. That's fantastic, because we do have some challenges in how we position Pano right now, particularly because there's a whole array of options as well for the treatment of myeloma.
Heather, well, how do you all do it in the city?
I think that I'm excited by the work that A.J. Chari is presenting, because I think that having an option for lenalidomide refractory patients, an all-oral combination without the associated GI toxicity or fatigue or the schedule problems that carfilzomib poses, then I think that this is a great option for our patients.